working meeting. It is November 7th, and we appreciate so many of you being on so early. We will go ahead and get started. If you want to go to the next slide. These are just a few administrative items that we go through at the beginning of every call. If you are new to these calls, you will get very familiar with this, but we like to share it every time so that anyone who has just recently joined is aware. We do record these calls, so everyone has entered on mute to cut down on background noise, but when we open up for discussion, you are more than welcome to unmute yourselves if you would like to speak, or if you're having trouble doing that, you can chat us using the chat feature, and please send all chats to everyone, because if you have questions or comments throughout the presentation, it's excellent if you can pose it to everyone, because we've had some great conversations via chat during these calls lately, and we appreciate all of you who follow the chat and add your input or help us answer questions while we move through the conversation. Next slide, please. If you have not already joined the Gravity Project, please do so. To do so, you go to the Confluence and select Join the Gravity Project, and you can join as a committed member or an other interested party, and the definitions for both are on Confluence, and we appreciate all levels of participation, regardless of how often or how infrequently you can come. Everything's posted on Confluence for your convenience, and we do post meeting materials after each meeting. But if you are joined to the project, you will receive emails from us, and those emails will have links to all the information you need as well. So take a minute to do that if you have not done so already. Today we will go through CPT final feedback. Sarah will lead you through that, and diagnosis updates, as well as the food insecurity working definition. That is a draft definition, and we've been seeking input on that, so she will share the latest updates. And then Donna is going to share the latest end-to-end review feedback, and then we'll go through next steps at the end of the call. Next slide, please. This is a bit of an updated schedule. We have the quality and the depth of the comments that we are receiving from all of you has led us to many internal conversations, and the opinion that we need a little bit more time, and we need to give all of you a little bit more time to continue considering some of the things that we have put forth in the last couple of weeks. It's important that we get this right now, instead of trying to rewind or retract or redo later down the road. So in order to do that, we have pushed off consensus voting a week. So instead of starting next week with consensus voting, we're going to give everybody another week to kind of get your heads around what we're asking and give us more feedback or any further thoughts that you have about some of the things that you'll see and hear today and next week. And next week, we're going to have kind of an open forum call. There may be a little bit of structured status updates for you, but what we really want to do is get a sense of how you're really thinking about some of these things that we'll cover today. So if you look at the schedule, the 14th, next week, is more end-to-end comment review and dispositions. And really, this is what I'm talking about for the open discussion. And then for the 21st, we will go through the food insecurity consensus voting process with you so that you all know what the ask is and how to place your votes. And then the next week, everybody will be hopefully spending time with their friends and families. And then there is no meeting on the 5th because we're going to need some internal time to reconcile all of the feedback that we get from you for consensus voting. And just as a side note, for consensus voting, we do expect 66% of our committed members to vote. So if you have registered as a committed member, we expect you to vote. We ask kindly that you do so. We highly appreciate your input. And if you need to change your status, you can do that via email. You can email us, or you can change your status on Confluence. And then the 12th of December will be the last meeting of 2019, and we will present those consensus voting results and dispositions. And then Lisa Nelson will give you an idea of what's going to come up for the Fire Implementation Guide review process in 2020. Next slide, please. At this point, I will hand it over to Sarah. Sarah, if you want to take the wheel.
Hi. Yes.
Thank
so
you.
I have a few items to present on, mostly updates on things we've asked you to do and consider before, and then an update on something you asked me to consider. So First of all, the CPT update. We've received no emails objecting to the way we framed CPT based on the last meeting, which was to not address professional CPT per se in our submission in the value set and data set, and instead focus on the more granular elements that are contained within screening CPT. Um, this has been a very busy food insecurity day for me today. So I was at the Hunger Vital Sign National Community Practice meeting at lunch, and then I was at another meeting at 2 o'clock for the Food is Medicine work group. And I've gotten a few bits of feedback on this since that statement that I didn't even have time to update the team on, which is mostly that we um, need to consider hick picks here as well. So we have to fold back in around that. And that came out of the lunch meeting that I had. And then also considering the proposed medically tailored meals, hick pick in that as well. So as we roll forward with our work here in Gravity, we really are trying to make sure that we include as many of the community members who are out there as possible. So part of that is presenting this work to work groups that are working on it in other settings. And so in addition to this CPT update, which is, again, not focusing on the professional CPT and focusing on these screening elements, I have a little bit of work to do to integrate some of the HCPCS codes that are proposed for medically tailored meals and such. And I will include that in what we present next week. So I have homework on that count. Anyone with any questions on that bit? I suppose I'll present my three.
There's a comment in the chat. It's from Larry Simon. If you can see your chat. If not, I can read it out loud.
Oh, yes. And so what the commenter is echoing something we discussed before, that CPT2 would be very, very useful. And again, I have I feel like I'm sitting on many panels these days, but one of them is the NQF Food Insecurity Quality Measure Development Panel. And hopefully CPT2 codes will be able to be built off of those eventual quality measures. That's definitely something that we intend to do. Next slide, please. And this is the diagnosis update. We took last meeting, we reviewed some comments from the community asking us to delve into further specificity on food insecurity modifiers, basically. And I mentioned that I would try to map out what that looked like, and then I had homework to present this to kind of a working group of a core cadre of food insecurity subject matter experts that I count as colleagues at Feeding America and the Food Research and Action Center and Children's Health Watch, and some of them are on the call right now. So this is what would be possibly mapped out if we built out all of the specificity on food insecurity. So you would have the severity of mild, moderate, and severe. And then you could have temporal modifiers of the chronic, recurrent, transitory, and transitory applied to each of them. This mimics, again, what happens in other history-driven diagnoses, such as depression. Depression is one thing I always kind of reference in this space. And then there would be a parent code of food insecurity unspecified to allow the observer to not further define. So far, the feedback is definitely it's kind of mixed, and we'll go further into this next week. I think part of our open call is truly trying to delve into this more deeply next week, next Thursday. But there's a fair bit of support for the mild, moderate, and severe, and some concerns regarding the temporality features. And we can think about that more next week as we go forward. I do want to add, again, trying to understand the comments from the community at large who may not be able to make these meetings. There is some question that we really need to make sure that as we represent specificity, we also account for just the overburdened clinician that wants to be as simple as possible. So we have to keep both of those things in mind. So this is why this unspecified code would be an option for them to just get something in the record and move on. Oh, hi, Al. Al has a question. I'm sorry if I've missed this, but is there a plan to develop steward value sets in VSAC and or HL7? Lisa, are you there? Lisa, do you want to answer that one?
Hang on, let me see if I can unmute you, Lisa.
I was muted twice. There we go. I'm unmuted now. I'm typing away to Al's question right now. I'm 2 seconds into it. But yes, all fire IGs have elements that are bound to value sets. The value sets have to be registered and findable in either UTG or a place like VSAC and before something publishes. But we will be, while we're testing the IGs, we will be working with placeholder codes that are stored within the context of the Trifolia IG. That's how implementers will get access to the codes while they're testing. And then once things are confirmed and we work with the code system SDOs to get the needed codes issued, we will then develop established HL7 value sets that reference those code systems.
Thank you, Lisa. And I want to take a moment now, and thanks for your question, Al. I want to take a moment to answer Jane and Donna's question. The definitions of these concepts will be built off of the severity qualifiers that we presented last week, which correlate to the WHO FICE tool and the USDA food security module. So those definitions would be clearly defined, and we are very cautious to build anything that is unclear, which is partly why we're hemming and hawing on the temporality issue. That answered your question. Okay, next slide. So again, we're just revisiting, again, the gravity working definition. I want to take a little moment to, again, present this clearly and say why we are here. So initially, when we started our work, and we're going to reference again the definitions that are on the Confluence webpage, we were using the USDA definitions of food security and food insecurity. There's some concerns with using those for the project because, number one, they don't necessarily contain exactly the same concepts, and so it's difficult to plug those definitions into computable logic. And number two, the USDA definition of food insecurity is operationally had the difficulty of being linked only to economic resources, and there's many more drivers and domains of food insecurity. So this is, again, the working definition of food insecurity that we have it right now. We will talk more about this next week, but we wanted to take a moment just to remind folks about where we stand. So the definition of food insecurity would be uncertain, which allows for that not knowing where it's coming from. Limited, meaning actually experiencing a limitation. Unstable, which allows for fluctuations in access. So uncertain, limited, or unstable access to food that is sufficient in quantity. So you have that quantity domain. Adequate nutritional quality. So you have the quality element. Culturally acceptable, which is now necessarily known as a very important concept in food insecurity, but is, as we understand it right now, difficult to measure in screeners. We don't really have tools to do this, but it can definitely come up in history. Safe, meaning it's safe to consume, and then that acquired in socially acceptable ways, because we wanted to make sure this is a key component of many of the definitions of food insecurity, and this is to ensure that someone is not simply food insecure because they're relying on emergency food resources. So it is important to understand that everyone has a right to be food insecure that is dependent on socially acceptable acquiring of that food. So this is the working definition as it stands. All right. Any questions on those three slides? Those are my 3 bits, the CPT, the severity qualifiers, and the definition. And we're going to have this open kind of seminar about these concepts next week, I think. We wanted to make sure that we did our due justice and responded to you about these concepts. Seems like we're good. Okay, moving on, Donna.
Thank you, Sarah. I appreciate it. Good afternoon, everyone. I've been charged with going over the end-to-end comment review, and this is organized around the areas within the data set. So we're going to begin with screening and assessment queries that we've received. We'll move on to a discussion of goals, and then finish with queries that we've received related to interventions. I didn't mention diagnosis because we have not received any feedback related to diagnoses, although we're still accepting feedback. So please make sure that you continue to send us that information. But we thought it would be helpful to go over these queries that we've received thus far. So beginning with this one, the hunger vital sign panel questions. We received a question about this. And just to recap, the hunger vital sign is a validated 2-question screener with a focus on quantity of food, which admittedly is only one aspect of the present working definition that Sarah covered of food insecurity. The other characteristics of nutritional quality, culturally acceptable, safe, and acquired in socially acceptable ways are known to be absent from this screening tool. This is a recognized limitation of the hunger vital sign. So while this is a valid screen for food insecurity, really takes a professional then to use clinical judgment to evaluate the hunger vital sign information along with other information gathered from the patient to make a determination about the presence or absence of food insecurity. Next slide, please. The next 2 slides touch on a concept related to the patient of record and the complexity of social determinants which can occur in households. The query raised asks whether patient should or could be patient and family. Many of the screening questions do evoke the family when in reality not all patients have a family. For most of the tools, the concept of household is used rather than family in recognition of that fact that not all patients have a family or choose to live with their family. So we need to think about then, what does the use case tell us about this? Well, based on the use case that was developed and agreed to earlier in this work, the subject of observation or of record is the patient and not the household. Next slide, please. Additional questions from screening and assessment tools, as I mentioned, do reach beyond the patient of record, as you note here. Questions include we, other members of the household, or a child. These are, of course, how social determinants occur in the context of the members of a household. For the project at hand, the use case supports data elements for the patient of record. So this is within the scope of the current work. But one very important recommendation that will be identified as part of the Gravity Project report is the critical need to represent a member or members and a child or children in a household during electronic data exchange. Next slide, please. So also received as part of the feedback was a suggestion of a concept related to reliance on others for food. We acknowledge that this may be a facet of food insecurity, but reliance on family, friends, or other resources can come in many shapes that vary depending on the resources and/or the patient's relationship to that resource. So this would need much more exploration before it could be known or would be known how to assess this concept for individuals. Another piece of feedback that we received is that the concept of the past year seems like a long time frame for recollection of food insecurity issues. As many of you already know, this is based on the use in USDA tools that look at the economic parameters for the previous year. But other tools that are included in the data set, such as the FEIST tool, do contain questions that involve shorter time frames. So it certainly is feasible within what has been proposed that there would be different timeframes used. Interestingly, should the community consider temporal factors, the reflection throughout the past year might yield information about the nature of the food insecurity in terms of whether or not it's chronic or transitory. Next slide, please. Now, the last screening or assessment query that we received relates to a possible area for screening or assessment is that of the breastfeeding mother. This is in scope. While not expressly in the use case, it would be covered by the elements in the data set, because in this situation, the breastfeeding mother is the patient of record. So the screening and assessment tools, as well as all of the other data elements for food insecurity, would meet this need. So I'm going to stop here. There's been a lot. I haven't been able to keep up on everything posed in the chat, but I wanted to stop at the end of screening and assessment to see if there's feedback from the community so far. Okay.
This is Annette. As a reminder, you may need to unmute yourself if you're trying to speak. And if you're phone only, I think it's *66 to unmute yourself.
Okay, well, there's always an opportunity for individuals to raise any thoughts that you have as we continue, so please feel free to do so, even if we've moved on to a new area within the data set. As I mentioned, we don't have any items in diagnosis. We've not received any feedback in that area, but on the next slide, you'll see a suggestion that was received related to the goals that are listed. So on the left-hand side here are the current goals, and these are common to food insecurity and familiar to many of you who are on the call. This is what is consistent in the literature, collecting information about the incidence of food insecurity, as well as concepts such as decrease in the severity and prevalence of food insecurity. Brought forth, though, is a recommendation for the community to consider, is there an opportunity to include more person-centered language for the first goal, labeled as G1, and that's the way it's listed on the master as well. The idea is to rephrase food insecurity to client achieves food security. This brings the focus back to what we're striving to achieve, that is the client achieves food security. So at this point, I'd like to open it up and ask if the community has any feedback regarding or any concerns about rewording Goal 1.
Donna, this is Lisa. Just to be devil's advocate, I'll ask: has anybody thought about the words patient no longer has food insecurity, or something food insecurity no longer present, something like that, where the observation when it is present, we have food insecurity is present, it's absent, or I think there's a third possibility, like not evaluated or something like that. But have we thought about wording the goal in terms of food insecurity to say that food insecurity would be absent or would no longer be present?
I'd love to hear what the community has to say about it. Got one individual that suggested improved.
I think I would agree with Lisa that in terms of coding, we do need to retain a code that indicates that there's a problem. And this excellent rewording, however we word it, is a code for outcomes. Have we been consistent that we want codes for outcomes, positive outcomes in particular, for all our domains?
So we do have the diagnoses, which do label the problem. So there are those codes that exist to identify food insecurity. So I think that we've been consistent in keeping that. And then the goals have been framed around what we'd like to see happen. And that's why this wording, in terms of the way these are written, is the way it is. It's also in some ways tracking actions that have happened. So identifying when food insecurity screening has occurred, since that's common to also record when screening and intervention have occurred.
Thank you. I guess in terms of actual wording, maybe it would be a little more cautious to say client reports achieving food insecurity, since I mean, if this is this a fact or is this a reported situation? I guess that's the question I'm raising about the wording here.
It's a good point. I think that we have looked at this goal as being a fact. However, it certainly could also, there could also be a reported concept. What does everyone think?
Well, goals have a nature that's different than, like, if you say fact, I think of that as more like an observation, where the semantics of a goal is actually different. It's sort of related to an observation in its heritage of how it came, how its structural meaning and semantic meaning all comes together, but it's really a thing that stands on its own, and it really is a goal. A stated goal, and there's nuance to say whether the goal is a goal that's set by the practitioner, or the goal is set by the patient, or it's a shared goal for both the patient and practitioner.
Lisa, this is John Ritter speaking from school child's perspective. This is not a client nor a patient. You don't have a practitioner involved, but you do have social services, or perhaps a school nurse or some other organization that helps provide food for children through a backpack program, or early morning lunches, or fruit that's laid out in the hallway on a table, or picking up food after the students leave the cafeteria to take it home. So there are many, many different ways to mitigate that. On the other hand, if you ask a student whether they've had enough food, if their reply is untrustworthy, they may respond and say, "I've had enough food today," or this week, not knowing that their father's about to lose a job or something next week. So they really are not, adequate historians with respect to answering the question that would cause someone collecting the information to legitimately put down food insecurity has been mitigated or not. In other words, it's a complex question and answer.
Mm-hmm.
This is Al from ONC. I had a thought about whether or not we ought to be able to encode resolved or improved. It may fit into the severity scale. We may consider adding maybe two codes to the severity scale, including improved and resolved. Just a suggestion.
Hi, this is Ruth, and just I'm thinking about this from an evaluation perspective, and it seems that it's important to not consider codes just in isolation as you move along the, the process, the care delivery process, and that, to assess whether or not goal is met, unmet, or outcomes are achieved. It seems like, if you're thinking about doing analytics on this data, that there has to be a way that you can actually manipulate the data to show the progression from identification to resolution to improved outcome.
Donna, can you do me, this is Sarah DeSilvi, can you do me a favor and just refresh us on the primary ask of this slide? So we have some comments regarding the utility of goals. We have some comments regarding how to phrase them. And then Al's comment actually relates to one of the adaptations we made to goals in reference to severity that came from Dr. Meyer's suggestions. So can you just help orient us again to the primary ask of this slide?
Sure. So I guess what we're trying to get at here is whether or not there is use in re-looking at the concept of food security and placing the client in the driver's seat and saying the client achieves food security. Is the community comfortable with rewording it like that?
I think the only hazard of that is that it doesn't, if we think about truly person-centered care, right? It would not be in their own voice, right? It would be third person as opposed to I'm achieving this, right? Because that's my only caveat. Is it in the world of goal setting, right? So if I'm thinking from a PCMH perspective, or I think of a plan of care perspective, or a shared care plan, it's what is my goal for myself, right? What do I want? What is the dream, right? So that would be my only caution regarding specifying the goal from the provider's perspective, whether it be the nutritionist, the case manager, social worker, nurse practitioner, etc.
Yeah, and I think that might have been why, initially we've just focused on what is the sort of the core concept, food security. We haven't framed it around who's expressing it. So I think that's something that we're going to have to go back as a group and try to determine whether or not it's appropriate to add those words, because you're right, this is not how the client would envision it or express it themselves. And so to provide that flexibility, we may want to focus on the core concept. Okay. I'm going to suggest that we move on then, because we do have actually another goal comment. Another concept where there actually are two facets potentially to the problem that we encounter. One, where an individual may be hungry right now at this moment, and two, may also require evaluation for ongoing food insecurity. Therefore, we're suggesting the community for the community to consider a new important goal of address severe food insecurity by connecting with emergency resources. In addition to recognizing the additional resources that go into connecting those individuals with the emergency resources, it also provides for a goal that, when reached, will enable the collection of important data to support agencies, policymakers, and communities. So this is another one for you to consider.
How about persistent instead of severe? Severe sounds to me unconstitutionally vague, and I don't know how that would be measured, or people may have different thresholds for what they might consider severe, but persistent, invoking the uncertainties of life or
So,
something like that.
Lucy, in this space, in the space of severity, the one thing I would encourage the group to do, we have the ability to clarify definitions, as was discussed earlier, but there's pretty broad notion of severity, and the notion of mild, moderate, and severe is the sort of the standard vocabulary that is used in that element. And I think what we would need to do, don't freak out about that word as a code. The codes really are fire tends to make codes that are more a readable code than just a number kind of code, like they use in LOINC or something. So the fact that the codes are mild, moderate, and severe, you have the opportunity to clarify for this type of observation mild severity means, and then go ahead and say and define what that is. But within the coded language that we use for severity, the three codes that are used right now are mild, moderate, and severe.
Thank you, Lisa.
So Lisa, this is John again. Does that mean that for mild or moderate, some other organization weighs in, like social services, but when the patient is dying and it's severe, the emergency team steps in and, brings a whole different class of nutritionals to the patient, right?
Yeah, so this is Sarah DeSilvi. I'm gonna put this in context about where this goal came from. It was coming out of the work that's happening in LA. And Dr. Myers, if you're on the phone call, you can step up. But prior to this, the only goal we had was really that we were screening and intervening, which didn't really build a discrete space for when you have a patient who has no food at home and you're trying to address the ethical and clinical and mental behavioral complexity of that situation. Like, how do you not let that patient go home to not have dinner tonight and to not have food tomorrow? So there was a request from a submitter to build space for that specific intervention, right? The goal is like specifically when a patient has no food at home. And again, that's very clearly severe food insecurity by all of the metrics that are out there, all the tools that are out there. When they have no food at home, and that, what do I do right now? My goal is to connect you with something right now, like whether it be sending you over to the food pantry, whether it be giving you the in-clinic food support. So this goal was built to address that unique situation that was really not captured within the granularity of the existing goals that we had.
Hi, everybody. This is Richard Stewart from Children's Health Watch at Boston Medical Center. To add some additional context, just this week, at BMC, we're interested in essentially assigning a level of risk to a patient based on their food security status. So, low risk, medium risk, high risk, and to have this ability to differentiate would be helpful in that context because it would determine what type of intervention might take place.
Thank you, Rich. Did my description help put it in context a little bit about why this was a unique ask? It looks like there's.
I just happened to notice that Myers is having trouble and he's phoning in again. So there may be information that he'd like to add if he's able to get on the call.
Hi, this is Lynette, and Larry Simon is also trying to comment, and I'm frantically trying to get him unmuted, so please stand by.
Okay.
We got a comment from Alyssa. I'll just read it out. Shouldn't goals be focused on what the desired outcome should be, not the specific processes that will be followed to achieve that outcome? Yes, and Lisa agrees. Do you want to say anything more, Alyssa?
Can you hear me?
Yes.
Okay. My point here is just that I know that there's a number of different value sets and concepts that are coming out of this process. And I think there's a risk that if we try to make the goals too specific, they'll end up overlapping with some of the concepts that are found in other areas of the work that's happening through the Gravity Project. And it may not be necessary to go into that level of specificity for the goals, because you can still document plans of action or follow-up activities or interventions separate from the goals in a way that allows you to document what you're doing about patients' screening result and their desired outcome of working with a clinician or a healthcare system or healthcare team to address it.
Hello? Am I able to be heard?
Larry, is that you?
Yes.
That is, yes.
Hey, excellent.
No, I've been following along. So I'm Larry Seymour, and I actually represent the Blue Cross Association on the CPT editorial panel. And the panel's had some interest in Category 2 codes along this front. But you know, the comment that I had looking at the food security data and as this has progressed is that there seem to be a lot of different goals from a clinician standpoint that we're coming after in terms of we have to both get providers, be they physicians, social workers, whomever, to enter the data, but then it's still not entirely clear what we're either gathering data, like looking at whether or not to have a goal, a code for a goal met or goal not met. Well, are we trying to gather data that can then be mined through hospital systems to identify patients in need, to set them up with care navigators, social workers, et cetera? Are we trying to find codes that can be data mined to code not only a diagnosis, but specific SDOH interventions and outcomes? Or are we trying to have codes that can be mined to see if medical or surgical interventions improved different things? You know, and do patients with food insecurity get worse outcomes after cholecystectomy, for example? And so those are sort of things that I'm sort of thinking about and trying to decide, do we want to have, you know, codes with goal met and things like that? Because those could be very useful for tracking outcomes. But in all of this too, we have to make sure that both the providers are aware of the existence of the codes, and there's already so many codes we're keeping track of, and then two, what is the carrot for them using them? And thinking more specifically about physicians, a lot of this is incorporated into the social history, but what makes me think about Category 2 codes is they're already sort of plugged into MIPS metrics, for example, and so you could have social determinants of health sets that physicians can use for documenting at least the interventions, or at least asking their questions when it comes to things like ACOs and medical homes and things like that. But that was my overall sort of 30,000-foot comment, was thinking about the overall direction of what we want these different code sets to be used for.
This is Lisa. I just typed in a quick comment there that all of this foundational work around the relationship between problems that need to be addressed, goals that are established as the desired outcome is identified, interventions that are planned and eventually completed or not, and then the assessment or evaluation of whether the progress is being made against that goal or whether the goal has been met or not met. All of that work already exists in the care planning work that has been done over the past many years, at least 5, worked on in a variety of directions and available in standards already like Consolidated CDA and in FHIR. So the semantics of expressing that goals have been met or that progress has been made towards goals, those kinds of things are notions that we will be borrowing from and building upon. And the important thing for us is to establish in the landscape of care planning that there is such a thing as a goal around addressing someone's food insecurity. And that's the simple concept that we need. Whether we decide we want to use one set of words or another set of words is really a simple notion that we're trying to establish with this goal, so that we have the ability to track through cycles of monitoring and doing additional interventions and confirming that stuff got done and that things were tried. And did they lead us toward that desired outcome or not? And that's the whole cycle like that. It already exists. It's not being invented for this purpose. Our purpose is being layered upon what's the framework that's already established for care planning.
This is Sarah. I just want to again try to figure out, making sure we understand where we're going with this. So the suggestion was born out of a desire to give a specific level of granularity and feedback regarding the goal of addressing this unique situation of severe food insecurity or food insecurity with no food at home. So I think we understand the context of why that might be important, but we did hear a comment from Alyssa about whether or not we confuse things by adding too many goals. And then there was also a comment regarding just basically wondering about this is basically written as a team goal, like a clinician's goal, to a patient's goal. So any further thoughts on this before we move on? Because I want to make sure that we understand the direction to go with this. So it looks like we had some +1s for Alyssa's comment about it possibly adding levels of complexity that can be addressed better in other areas. Does anyone have any further thoughts on that? No?
Okay. So then I guess I'll request next slide, please. So this leads us to the last area, which are queries that we've received related to intervention. Certainly, as organizations have spent more time reviewing the materials, naturally there have been questions about how their existing services might align with the concepts in the intervention framework that's been proposed for the project. We're really heartened by this work that many organizations are involved in to ensure that the project contains all of the concepts that are used and needed in everyday work. Thankfully, additions and clarifications have been made to define programs such as the Food and Nutrition Incentive Program and other aspects that are listed here. And there's been favorable alignment noted by many organizations with the proposed framework. Inclusion of the patient engagement data elements also has enhanced the data set, and that was brought forward by this community. So we feel as though we're approaching where the intervention framework may have all the elements that are needed, but of course, we're certainly open to additional feedback from the group. Thus far, we have only received feedback that one concept that we had not previously discussed does not align with the current framework, and that's the use of interpretation services. In the use case that was developed, the preferred language was English, so interpretation services were not included as a potential intervention. Perhaps this is a place where we can reinforce that certainly in the course of care, all of you as providers offer the services based on the client need. Not having interpretation services in this data set doesn't preclude their use. At least based on the current use case, interpretation services are not included as data elements in the value set at this time for those reasons. Next slide, please. Can Evelyn or someone move to the next slide, please?
My apologies. My thing got cut. Please go ahead.
No worries. Now, because there are so many intervention data elements, when you look at the master, we have received questions about the difference between several like concepts. So these are just a few of those that were where we received a question. 3 that are related to education, but are based on 3 different food insecurity programs. So the definitions for the programs are provided in a separate tab in the master file. And as we've noted, we welcome the community feedback on any of these definitions. So that concludes all that I have related to interventions. Is there any feedback related to that concept in the data set? Just checking through the chat to see if there's anything that might be important to cover.
There's a positive response to Larry Simon's consideration. So I think Ruth also just commented as well. So I think that's something we can take offline as well as for your, or include as discussion for next week.
Sure. Yeah, I've seen a couple of other things come up about education, about access to food that's adequate and nutritional quality. There are less specific education codes that are included, so certainly that's where that would come in. And any kind of food pantry would fall within the concept of food pantries that are listed, rather than having an individual code for each type of food pantry. We elected to have a broader concept unless multiple organizations requested a particular subtype of food pantry. Let's see, what else?
There was a question regarding the education regarding nutritional food options, and this is definitely the wheelhouse of the A&D. I think this is, Alyssa asked, where does education about access to food of adequate nutritional quality come in? Donna, as the A&D rep, do you want to step in?
Sure. That certainly falls within the education codes that are listed in the master. There are a number there, and in fact, they're stratified as well. Not only by whether or not the education is about the content. So if you're providing information about healthy food choices, we would consider that more content related education. But let's say you're providing skills training on preparing specific foods that are healthier. There is a skills education code as well that would be used. I'm not sure about the social work codes question, so I'm wondering if we could hear more about that from Stephanie. I don't know if she's trying to unmute herself and.
Okay, give me a second. Stephanie, I'm unmuting you from here.
Hi.
There you are.
Okay, great, thanks. So I was just in a meeting earlier this week, and someone who's really experienced in all of these was talking about the various codes that are being used, link codes, the regular EMR codes, but he referenced a separate set of codes that I hadn't heard of that were codes used by social workers, and I think that they were maybe for interventions. I'm not so familiar with them, but I've emailed him just to see if he can give us some more guidance. So maybe I can just email this group. And he was talking about some work elsewhere, I think, that's being done to map as well to consider those codes and how to get a hold of those. So I just wanted to make people aware of that. And you can just tell me who on this group I could email, and I could, yeah, maybe this airs.
Yeah, I think it's there.
Yeah, we were just, so Evelyn and I had the honor of sitting with the director of LA 211 on Tuesday to understand how we can better map the data that's coming from the healthcare space to the data of AIRS, which for a long time has represented content knowledge in the community space. So I do acknowledge that that's a vast resource of granularity. The taxonomy is pretty robust. We just have to figure out how to speak well to each other, but that is absolutely necessary work.
Okay, okay. Thanks.
Thank you. All right, well, noticing we're getting close to the top of the hour, I wonder if we should move on and learn more about what is next.
This is Lynette. What we have coming up will be focusing more on fire implementation guide work in early 2020, and it's coming up very quickly, as I'm sure you are all aware. There is a Connect-a-thon scheduled for Q2, and you can sign up. If you're interested in attending that or participating in it, you can sign up. You're not committing to anything, but we're just trying to get a sense of who we should be reaching out to for participation. And this link, we can also include this link in a follow-up email. Again, if you have not joined the project, please do so, and you will receive those emails. But you can also email us at gravityproject@emiadvisors.net if you don't want to jump on Confluence. And we're trying to get as many participants as possible for that activity so that we can get some good testing of the fire profiles that are going to be developed around our use cases. And Lisa Nelson will have more information on that during the last meeting that we have on December 12th. Are there any other questions, ideas, thoughts, concerns? Okay, excellent. Well, we deeply, deeply appreciate all of your input today and in the past weeks as we're trying to hash through all these difficult conversations. And we hope that you will all join next week's call for a continuation of these types of discussions. If you have any questions in the meantime, feel free to email us and we are happy to reach back out to you. Have a great rest of your afternoon and we will talk to you all next week.
Thank you, everyone.